Thank you, David. We'll now move on to public comments. We have one public comment from Leah McCormick Howard from the National Psoriasis Foundation. We're asking all of our commenters to restrict themselves to 5 minutes since we have a very busy agenda today. Celia does have a stopwatch that she will run, and we'd also like you just to make sure that you state any conflicts of interest before you begin your comments.
Great. Thank you very much. Good morning. As you've heard, my name is Leah Howard, and I'm the National Psoriasis Foundation's Chief Operating Officer. As is indicated on your materials, it was up on the slide earlier today. I have no personal conflicts, however, as an employee of the National Psoriasis Foundation, I do just want to disclose that we engage with all of the manufacturers that are in our space. On behalf of more than 8 million Americans living with psoriatic disease, I appreciate the opportunity to again be with you as you deliberate and vote on the effectiveness and value of the targeted immunomodulators for the treatment of moderate to severe plaque psoriasis. My aim this morning is really to offer a few perspectives on behalf of individuals living with psoriasis, as well as the clinician experts who specialize in caring for our community. It was not all that long ago that NPF's VP of Research, Dr. Mike Siegel, stood before you in Boston to share the perspectives of the National Psoriasis Foundation during ICER's first review. If you missed his comments, certainly we invite you to check them out on ICER's homepage. They're still there. During his remarks, you heard about the heterogeneity, the complexity, and the uncertainty of living with psoriatic disease. He talked about plaques presenting in different severities, various body locations, and the uncertainty related to the dizzying number of comorbidities associated with psoriasis, and finding treatments and the complex decisions that both providers and patients face with regard to treating a chronic disease such as psoriasis across an entire lifetime. What he ended his remarks with was this sentiment, that while there's a lot of uncertainty, we know from NPF survey data that the burden of psoriatic disease remains. We know that the majority of patients report psoriasis to be a problem in their everyday life. We know the majority report dissatisfaction with their current treatments. And we know they are not treating to the level appropriate to the severity of their disease. So he encouraged an effort like the Psoriasis Review to really break through that and to reach those patients and get them the best possible health outcomes. So as you have heard, it's been a year and a half, and not much has changed really in our space in many ways. Psoriasis is still a complex disease with much uncertainty. We talked about patient experiences still being very much what they were a year and a half ago. So while we've seen new therapies come to market, something of course patients and providers are always eager to see, we still have significant room to go in getting patients to treat their disease to target. The mission of the NPF is to find a cure and improve lives, and as part of that mission, we want all patients treating at an appropriate level of disease severity, and for the patient-provider dialogue to be at the heart of every treatment decision. For this work, particularly within such a heterogeneous disease and heterogeneous population, we want as many treatment options accessible to as many patients as possible. Historically, data has shown us that treatment choices, access opportunities, and the need for more knowledge to inform decisions leaves a lot to be desired. This is the challenge that the NPF works on every day, and the good news is that we've made a lot of progress from a policy standpoint in the last year and a half to improve access for patients with chronic disease, preserve provider choice, and clarify how patient and providers can access more of the tools in the toolbox. As we shared in our written remarks prior to this meeting, we would encourage ICER to be sure that as part of this treatment update, the important role that you play in supporting individuals living with chronic diseases such as psoriasis, having access to good value therapies, not be overlooked. From a patient community standpoint, the 2016 findings were really as good as it gets. All the therapies were determined to be of good value. The work reflected patient concerns and included patient input, thanks to the work of the NPF and others. And the policy recommendations accurately capture the challenges associated with the reviewed therapies. Unfortunately, an analysis of several markets has confirmed that what we've heard from patients through our patient navigation center, that even with these new therapies coming to market, patients don't have many more options to choose from when it comes to treating Most formularies offer only a limited number of treatments, and as one member of our medical board stated to me, while experienced clinicians know based on data and their clinical experience that some medications are more likely to work better, he doesn't see the playing field being level enough to make a balanced opinion until there's greater transparency in the process. So as we conclude this condition update, that's a sentiment that I would like to leave you all with. How do we make a value assessment something that's real and meaningful to patients because it positively impacts their health, opens up access to therapies, and helps experienced clinicians take in an individual who's been struggling, feeling frustrated, angry, and helpless, and turns their life around because they're on the right therapy from the beginning.
Thank you very much. Are there any questions from the CEPAC panel? Any from the ICER staff? Okay. Seeing none, we'll now move on to the manufacturer public comment and discussion. And so we'd like to invite our manufacturer representatives to the main table, please. We have Brad Stolchik from Amgen and David Kaplan from Celgene.
And I will be running a public timer. I didn't have it up for you, but I will be first so that everyone can keep track.
We ask that you please introduce yourselves and then also state any additional conflicts of interest that might not appear on the slides.
Sure, I'll go first. I'm Brad Stolchik. I work for Amgen, no additional conflicts of interest. Do you want me to start? Okay. Good morning. Again, my name is Brad Stolchik. I'm the Director of Health Economics at Amgen. And my focus is in inflammation diseases. I thank you for the opportunity to comment on the psoriasis conditional update. Since the last panel that we've had on these drugs, which was for RA about a year ago, we have a few less members up front here, and maybe it's the long distance up here to Vermont. I know I traveled over 3,000 miles to get here, but we really appreciate being able to be involved in the process, so thank you for letting us come. Amgen's commitment to psoriasis patients provided a safe and efficacious drug in Enbrel, and with its development starting over 20 years ago and subsequently becoming the first FDA-approved TNF inhibitor for both adults and pediatrics for plaque psoriasis. It was the start of transformative treatment options that allowed psoriasis patients with flaky, itchy, and painful plaques to benefit from clearer skin. This potentially allows patients to lead more normal lives without wondering what other people are thinking when they have exposed plaques, and integrate more fully in society's daily activities such as work, social functions, and recreational activities. A lot of this you've already heard today, so I'm not going to go into a lot of that in more detail. What I'd like to focus on now is, what have we done since 2016? In the analysis of 2016, that was the basis for this conditional update. We've heard that it already showed value for all these drugs. Even so, there are a lot of stakeholders that suggested ways to improve the methods in the model to better determine the benefits and value of these products. These were mentioned earlier and included as contextual factors and should be incorporated into the model. These suggestions included understanding the long-term psychosocial comorbid impact of the disease on these patients who have not been adequately treated and therefore may live with the effects of the potentially disfiguring skin disease. And secondly, importantly, is understanding the comorbidities that develop in these patients due to or associated with long-term inflammation and multiple immunologic pathways, including things like joint symptoms and figure deformities from inflammatory arthritis, metabolic abnormalities, atherosclerotic vessel disease, and heart disease. We know that several drugs in these categories have the potential to benefit some of these comorbidities. Incorporating these additional effects that go beyond the skin into the analysis and the model would have better characterized the disease and shown a more complete value for these products. For the current analysis, we've talked a lot about the short-term PASI score that was incorporated from the clinical trials and the utilities assessed on it. But as we've heard, these treatments have long-term benefits on disease comorbidities, which will result in better characterization of the drug value. While this assessment is not yet final, we ask that these additional benefits be considered both in the vote today, but also in the incorporation of the final model results. Just a quick word about Enbrel. Enbrel was the first drug that was approved in this space and is often the comparator, as you've seen. We had the thickest dark line in that indirect comparison work that was there. It continues to have an important place in the treatment of psoriasis, even with the approval of the newer drugs. It's demonstrated efficacy in the bio-naive and continuing patients after failure of other immunomodulators, and in patients that develop joint symptoms indicative of psoriatic arthritis. We know the true evaluation of effectiveness and hence the value of this drug should be whether the patient responds and remains on therapy. We know that the most cost-effective drug is the one that works for the patient. To that end, we know that some patients have used Enbrel for their psoriasis continued since its launch over a decade ago. The long-term use in these patients shows the benefit of it being safe, tolerable, and effective. And there is a need to keep Enbrel available for these patients who may not benefit from a formulary-induced switch to another psoriasis drug. Concluding, patients and treating physicians need options when considering initial and subsequent psoriasis drug choices after the non-targeted drug therapies. They need to be allowed to maintain this effective therapy without payer introduction. Physicians and patients also need the options when patients stop responding to therapy. This assessment should account for all these benefits of the drugs, clinical including comorbidities, psychosocial, and the economic, to show their full value, which, as outlined earlier, has not been fully represented in this assessment and is needed to preserve the access to these important psoriasis drugs. Thank you very much.
Actually, Rob, can we give Reiner and or Dave an opportunity to respond?
Just one comment to the comorbidities, something I mentioned on the slide. Indeed, the cardiovascular disease especially is very important. We observe that patients with severe psoriasis have reduced life expectancy of about 3 years. The question is, where does this come from? So is it the comorbidity? Is it the disease? What is the relation between the disease and the comorbidity? So we are increasingly aware that psoriasis is a systemic disease. So indeed you can see some vascular changes. But this is currently still at the research front. What is important, however, is that we have found no evidence that treating patients with psoriasis impacts the comorbidities of cardiovascular disease. This is why we did not take into account any impact on comorbidities in the modeling.
Thank you. We'll move down now to David.
Good morning, my name is David Kaplan. I'm here on behalf of Celgene, manufacturer of apremilast, also known as Otezla. I'm doing consulting work currently not only for Celgene, but Pfizer and AbbVie. I'm board certified both in dermatology and in internal medicine, practicing as a clinical and academic dermatologist for over 30 years. Like Dr. Kimball, I've also treated thousands of patients with all these drugs, lectured and published on psoriasis over the years. I want to say from the outset that I feel that the ICER panel should know that I think Otezla should not be part of this review. I'm speaking not only as a clinical dermatologist, but also as a kind of an academic dermatologist. Majority of my patients that come in actually prefer not to be on a biologic. If you take a look at the MPF data, they'll tell you that the majority of patients with moderate to severe psoriasis actually are on topical therapy and not on systemic therapies. And this has to do a lot with safety, not because of lack of efficacy. And I usually look at the patients as a clinician in the real world in two different ways. I see at patients not in terms of PASI scores, moderate to severe. It's patients that do well or are happy with topical therapy, but then everybody else. Otezla is not a biologic. I see it as a non-targeted therapy. Unlike the other ones which seek out specific cytokines, this is a non-specific one as well. I agree with MPF medical experts that it wasn't really appropriate to include Otezla in this treatment category when all the other medications are biologics. Because of that, I'm concerned that this report will negatively influence my ability and other clinicians to treat patients in a manner that both we'd like to choose and our patients like to choose. Classic anecdote, I have a bunch of anecdotes, but a couple ones I like to present. I have a patient that presented, needed systemic treatment for psoriasis, looked at the various treatment options, and we wanted to start with Otezla because of safety issues, because she was a cancer survivor. Her insurance insisted that she start with the biologic first and fail before she'd be allowed to use Otezla. We appealed it and it was failed. And it was basically on efficacy data alone. And unfortunately, as a clinician, I have have to, as we all do, have to look at all the parameters and not just efficacy. So just because a PASI score is important doesn't mean that's the only consideration. I have other patients in mind that are consideration. My brother has severe psoriasis, including patient involvement. He was initially started on biologic, but I was able to transition him to Otezla because of safety issues. He's an emergency room physician, and again, because of exposure to various pathogens, he felt much more comfortable. And actually, surprisingly, did better on his Otezla than he did on his original biologic. I had another patient who came in recently. He was an engineer, needed systemic treatment, looked at the various treatment options, went everything from all the non-targeted. It's like this form that tried to say Otezla to all the biologics. At the end of it, I said, given what I think with your situation is, I think Otezla would be a good start. Looks at me and smiles and said, I did my research on the internet. I found the same thing. My patients out there are like everybody else in the room, use the internet. They're finding information, but it's balanced. It's not just efficacy. They're looking at the side effect issues as well. So me as a physician, I need to be able to have all my options available so that I can discuss them equally with everybody. And I feel sometimes that these reports handcuff me in terms of my ability to offer patients all the options. And I do use all of the options. Using PASI 75 scores, to me, is a problem. I have done clinical trials with the PASI 75 as well as other scores. I was unable to provide pictures showing you that I can show you pictures of people with PASI 50, PASI 75 scores that actually clinically look better than PASI 90 scores. It doesn't really accurately reflect. At the end of the day, when my patients come back in, are they happy with treatment or not? And the majority of my patients are typically happy, and if they're not, then we talk about the options. But it's not based on a PASI score. The 16-week cutoff that they use for this is, I think, inaccurate. This is not a 16-week disease. A lot of these agents do change, and patients evolve over time. So the question is, where are they at 6 months and 1 year? So using that as a primary endpoint is an easy one, but I think it's also not as robust as it could be. The other thing, again, we talked about patient satisfaction, but also PASI scores don't often reflect psoriasis in areas such as scalp, genital, hand, foot. It doesn't, even if they clear all the other areas, if they have involvement in those areas, they're not going to be happy to treat it, even though they may have an adequate PASI score. So we have to look at other considerations as well. Basically, in summary, I really see this as a great preliminary comparative analysis of most, but not all, the systemic treatment options currently available. Until you do the full comparative analysis, I think you need to look at the diverse clinical picture that I face every day in my practice, and also what patients prefer. I want to have access to medication, and this is a great introductory paper, but I think it needs to be expanded upon. I don't want it to be used by insurance companies or government agencies to provide generalized treatment guidelines for any specific patient that comes to my practice. I don't want it to have further impediments, which I already have in my office, to allow my patient treatment options that best meet their needs. Thank you.
Thank you. I'd like to invite the ICER staff to respond to any of the comments.
Yeah, hi, Dave Easter, University of Washington. I just make two comments. One is that there's absolutely no reason not to include a therapeutic option because of the mechanism of action. So, the point's not clear to me. The other thing I have to point out is that our analysis actually shows that using apremilast is potentially a reasonable option. I think I pointed that out in one of our slides, and so I think it's kind of maybe a little bit more in-depth discussion about the report potentially would be helpful to gain an understanding around that issue.
Before we transition to,
maybe just another comment. I think what everybody's looking for are clinical practice guidelines for psoriasis. They will be coming out, hopefully this year, I think. We hope that our report is going maybe to support some of the orientation of clinical practice guidelines, but our report is not being done to cover the whole spectrum of practice. That's a principal practice.